Good afternoon once again. I believe it's 10 minutes after the hour 12, and I'm sure we can start with the webinar. The others may join in as we go on. The initial plan was to start exactly at 12 midday GMT and 2 p.m. South African time. I'll just give a little background to this event that is happening today. We, as AFEM nursing and as a leader of AFEM nursing, feels that we need to have a monthly webinars. The idea basically is to keep our nurses in the loop with regards to new trends in the care of patients who present acutely. And so on this basis that we decided that why don't we have monthly webinars to update our nurses with the events that are happening around the world and in the field of emergency nursing. And this is the reason we have this webinar. Hopefully next month we'll have another one, and we hope to continue this as far as the association still exists. Without taking much time, we are already 11 minutes late. I want to begin with the slide. We'll just zoom in straight up to our presentation. I believe everybody can hear me.
Yes, all good.
Thank you. So this morning we'll be discussing trauma in nursing, and this is going to be more or less a recap of the very things some of us already know. And so we hope it's going to be interesting and it's going to be interactive too. Our objective for this afternoon will be to demonstrate the primary and secondary patient assessment, establish priorities in trauma scenarios, initiate primary and secondary management, arrange disposition of the patient. Now, we want to also look at the 3 modes of death distribution amongst trauma patients. And if you look at my slide, I began to divide this into 3. We have the first peak, and this is basically individuals who are involved in trauma who die instantly, and it might be as a result of brain or heart or large vessel injury. And then we have a second peak, which occurs from minutes to hours after the trauma has taken place. And the third peak occurs days to weeks after the trauma. And this may be as a result of sepsis, multiple organ failure. But as emergency nurses, our focus is on the second peak, deaths resulting from traumatic brain injury, skull fractures, orbital fractures. And these patients are usually in our care. We continue penetrating neck injuries, spinal cord injuries, cardiac tamponade, tension pneumothorax, massive pneumothorax, esophageal injury, diaphragmatic herniation, flail chest, sucking chest wounds, pulmonary contusion, tracheobronchial injuries, penetrating heart injuries, aortic injury. These patients usually will be in the hospital, and we have opportunity of taking care of them. And we have a responsibility of identifying these early enough so that they don't end up dying. How do we treat trauma? It is said that we treat the greatest threat to life first. And we do not wait for a diagnosis to start treatment. As emergency nurses, we know that we don't need so much history. You need to attack the patient the moment they present to your facility. And a detailed history of the trauma is not necessary to begin the care. Always and always remember to start with your ABCD approach. There should be a systematic way of seeing these patients when they present. Initial assessment and management of trauma patients begins with teamwork. An effective trauma system needs the teamwork of emergency medical services. Remember that in a well-developed emergency services, the EMT will usually let the hospital know that the patient is coming through. And once the patient is coming through and the hospital is in the known of it, the team assembles, roles are shared. Those who matter in the care of this trauma patient are informed. i.e. the laboratory is informed that it is a patient coming through. Can you get a certain amount of blood ready for this patient? Because we may not have an opportunity to know what blood group or blood type this patient may have. The nurses are involved. Doctors, X-ray technicians, and others are equally part of the team that are supposed to meet together and then resuscitate this patient. Trauma roles are shared. There's usually a trauma captain, someone who runs the trauma. And we have the interventionist. These are individuals who help out during the trauma resuscitation of the trauma patients. And of course, nurses who do the work. And then we have a recorder. That person is responsible for the documentations of almost everything, including treatment that has been given to this patient. Our primary survey. Patients are assessed and treatment priorities established based on their injuries, vital signs, and injury mechanism. ABCDs of trauma care. You want to look at airway, C-spine, motion restriction. Our B is breathing and ventilation. We are going to take this one after the other and go on with it. Circulation with hemorrhage control, disability, neurological status, and exposure plus environment control. Can we have those talking behind mute their mics, please?
And then I can hear them. Let me store this one for the first time in my life. Let me have something in my house.
Please.
So that I can be monitored.
Can you please mute your mic?
I have a lot of pictures. I want to discuss.
Let's call the meeting to order. Let's
Thank you. So airway restriction, airway with restriction of cervical spine motion. How do we evaluate a patient's airway? The airway should be assessed for patency. How do we assess for patency? Is the patient able to talk, inspect for foreign bodies, examine for stridor, hoarseness, gargling, pool saliva, or blood? Remember that you cannot proceed to the next if you've not been able to intervene where there's a problem. So for instance, if the patient is not able to talk, what is happening? What is making the patient not able to talk? If it's a foreign body and you can take it out, take it out. If it is saliva or a pool of blood in the mouth, you want to suction and evaluate to see if the patient is okay before you move on to the next. Assume there is always a spinal injury in patients with polytrauma. You might want to put in a C-collar at this point. C-spine clearance can be done both using images, X-ray or CT scan, or the physician may be able to evaluate to tell that this patient does not have a cervical spine injury. Spinal protection should remain in place until patient cooperates with clinical examination. What are some of the interventions we can do for these patients with airway concerns? Oxygen, suction, chin lift, jaw thrust. Remember, there are cautions with some of these with trauma patients with cervical injuries. Establish a secure airway. Remember that in the case of trauma, those days when we used to say that rapid sequence intubation has changed, we now have drug-assisted intubation for agitated patients with C-spine motion restriction. And some of the tools you can use in making sure that your airway they are not definitive airway, yes, but you can put in to make sure that you are able to sustain your airway. You have the various sizes of oropharyngeal airways and nasopharyngeal airways. And of course, the picture here demonstrates the various types of airways we have. The LMA, we have the proper ET tubes in situ for these patients per photograph that we have there. At this point, we are happy to move on to our B. What can we look for to assess a patient's breathing status? To assess a patient's breathing status, first of all, airway patency does not ensure adequate ventilation. You want to look, you want to listen, you want to touch. A deviated trachea, usually a late sign. Crepitus, popcorn chest, flail chest, sunken chest tube, sunken chest wound, absence of breath sounds. Your chest X-ray, if available, is always, a chest X-ray is always an adjunct to the airway, to the A and the B as well. But remember that you need to look. What are you looking for? Rise and fall of the chest. Are there any obvious wounds to the chest? You may want to listen. Auscultate the lungs to find out whether air entry is adequate and bilateral. Is it reduced? If it is reduced, what are you looking out for? A pneumothorax, a hemothorax, it could be reduced or absent. You want to touch. What are you touching for? Crepitus or subcutaneous emphysema. These are all things that will point you to a certain direction for the patient care. Complications of the chest trauma involves flail chest. Our image here shows a break in the continuity of bone in the rib of this patient. So you see that when the patient takes in air, there's a shift downwards. And when there's an expiration of air, there is always an outward look of that chest. So you see that there's what you call asymmetry of the chest, or some of them will call paradoxical movement of the chest. This will point us towards the direction of flail chest. Interventions for some of these injuries to the chest include chest tube. So you can see that there's a chest tube in situ for this patient. Further interventions will include to ventilate with 100% oxygen. Where you are able to tell that the patient has a tension pneumothorax, you may want to put in a needle decompression followed by a chest tube. A chest tube as a standalone procedure also for pneumothorax and hemothorax. Remember that a simple pneumothorax can develop into a tension pneumothorax. And in the case of an open chest wound, you want to do an occlusive three-way dressing so that at least there will be a point where air will not be trapped into the chest of this individual, the thoracic cavity leading to tension pneumothorax. If the patient is intubated, remember to evaluate a tube for positioning by auscultating. And of course, if you have an access to an x-ray, you want to do a post-intubation x-ray to determine placement of this patient. We'll move on to our circulation and hemorrhage control. Remember that rapid assessment of hemodynamic status, level of consciousness, skin color, capillary refill, pulse in the arms and legs, depending on the injury to that affected area, and blood pressure will fall under rapid assessment of hemodynamics for these patients. Shock should be considered on every trauma patient. And what are some of the types of shock we may want to find out trauma patient might present? Trauma patients may present with hypovolemic shock if there are loss of blood or plasma, cardiogenic shock if the heart is less able to pump blood, obstructive shock, physical obstruction reduces cardiac output, and distributive shock, disruption in the vasomotor tone of these patients. And trauma patients stand a chance of suffering from all these types of shocks. Hypovolemic shock, the physical loss of either blood or plasma due to hemorrhage or due to burns. And this patient would present with decreasing blood pressure, increasing heart rate, increasing anxiety until lethargy and unconsciousness set in, increased respiratory rate, decreased urine output. So you need to look out for some of these signs and symptoms. Output of urine is important in shock patients. You need to monitor by placing your catheter in situ to be able to tell how much fluid this patient, how much urine is this patient giving out, as against how much you've already even given to this patient. What are some of the interventions we can do for these patients? You monitor pulse and blood pressure continuously, apply pressure to bleeding sites, establish IV access to large bore IVs, volume resuscitation, have blood or fluid ready if needed. ATLS will talk about giving 2 liters and then blood. But if you have access to blood first, please go ahead and give your blood. You put in your Foley catheter, as mentioned earlier, to monitor your urine output. Unless there are signs of urethral injury, then you need to be cautious about that. Cardiogenic shock, inadequate contractility of the heart due to myocardial infarction, blunt trauma to the heart, arrhythmias, and cardiac failure. These may be rare in trauma cases. This patient does not necessarily need fluids. You want to do an ECG as soon as possible and put the patient on a cardiac monitor, and you want to treat the arrhythmia as the patient presents. Obstructive shock, and this may be due to physical obstruction or compression of the heart vessels around it. Remember, one of the complications of chest injury, cardiac tamponade, tension pneumothorax, you may need to put in a chest tube. And when there's a cardiac tamponade, remember that obstruction or compression of the heart vessels around it might not allow the heart to. And in case of tamponade, the heart is unable to contract very well for the circulation to take place. What interventions can we do under this? Remove the underlying obstruction. Hemothorax, pneumothorax, you want to put a chest tube in. In the case of cardiac tamponade, you want to needle decompress. Distributive shock, loss of vessel tone due to sepsis, unlikely in acute trauma. Neurologic, which is basically spinal damage. This patient will present usually with dry, warm skin, not sweating, and will have bradycardia. Interventions here, septic shock is treated with antibiotics. Neurogenic shock is covered under the next step, which is disability. Abbreviated neurological exams, AVPU, level of consciousness, pupil sizes you want to know. Are the pupils the same? Are they bigger? Are they dilated or constricted? If they are constricted, is there an opioid abuse or opioid use somewhere? If it's one side, one pupil is bigger than the other, are you thinking anisocoria? If it's an anisocoria, what are we thinking? What is happening to the brain? Motor function, and then you might also want to do the Glasgow coma score, the proper Glasgow coma score. And this is utilized in the determination of how bad this patient has in terms of brain injury. We have our GCS, the detailed ones. The initial GCS spoke about eye-opening verbal response, best motor response. In the revised scale, you might want to look at eye-opening. Under eye-opening, you have spontaneous, to sound, to pressure, none, which will score you 1, and non-testable. Now, non-testable here means that you're unable to put a numerical score, given that the region and you're not unable to put a number to where it is. So if you're not able to assess, for instance, if you're looking at eye opening, there's no spontaneous eye opening, to sound, to pressure, and none. None is 1. But if you're not able to test this eye opening, then you want to put in non-testable. If a patient has a tube in and you're unable to test, the initial writings was to say that a certain number T/15. Now you can actually put non-testable because you're unable to test verbal under verbal response. What are some of the interventions you want to do under disability? Spinal cord injury, you want to keep the spine stabilized. High dose of steroids may be used. This will be prescribed by your physician. You may suggest if you know, and it's not part of the patient's treatment. Decreased mental status may be a sign of elevated intracranial pressure. You want to sit the patient up if it's tolerated, and hyperventilation, basically increasing breathing and oxygen. Now, remember that in our settings as Africans, we may not always have access to a second CT scan. The initial CT scan might not be able to give us what we are looking out for, but the patient begins to deteriorate. You might have to look out and rule out elevated intracranial pressure in these kind of head injury patients. Exposure and temperature control. Complete disrobing of patient, what you call exposing of the patient. You want to cut the patient's clothes and have a good look of the anterior section and posterior section of these patients. And you want to log row at this point to inspect the back, whether there are injuries there, so that you don't miss any injury. You want to provide warm blankets to prevent hypothermia, depending on which area and region you are. Remember that these cold temperatures can cause further coagulopathy in this patient that might lead to patient's death. Always inspect the back of the patient. If you don't inspect the back of this patient, you are going to miss injuries such as what we are looking at on our screen. Now we have a case study, and we would like to have answers to this. We have a 28-year-old man involved in a speed motorcycle accident. He was not wearing a helmet. He's groaning and utters "my belly." His vital signs: heart rate 134 beats per minute, BP 87/42, respiratory rate 32, SpO2 is 89 on oxygen via non-rebreather. The patient is drowsy but arousable to voice, has large bruise over the left side of his scalp, airway is patent, decreased breath sounds over the right chest, abdominal pain to touch, obvious left ankle deformity. What are the priorities right now for this patient? And please mute your mic if you have the answer. You may raise your hand as well. I have the case study again. Do I have an answer from someone?
For the first time in a long time, I can see myself clear.
Yes, Mr. Carl Sylvia.
Yeah, you are welcome. I'm called Natkunda Sylvia from Uganda.
Hello, welcome.
Yeah, thank you for the webinar. My priority here would be securing the C-spine because the patient was not wearing the helmet.
Very well.
So there is a danger of the C-spine. So mobilizing the C-spine, breathing on a non-rebreather mask. I see this is 89%.
Yes.
So there is an additional of oxygen. It's not enough. We are not hitting the target in our B. I have another one about the BP levels are very low.
Yes.
So we need to think about our 2 large bore cannulas.
Excellent.
And there was another part of the decreased breath sounds on the left chest.
Yes. So you have concern with regards to the C-spine. What will be your intervention there?
To immobilize the spine by putting the C-collar.
Excellent. Is there somebody else who want to give a further answer to this one, to this very scenario? Yes, please. Go on.
So I would also consider the because we are getting SpO2 stats 89.
Okay.
Or non. So I'll also take that into consideration using the ABCD model and also secure the seat.
Can you repeat what you want to take into consideration, please?
So as I said, I'll take into consideration the oxygen saturation.
Okay.
Which is 89% on non-rebreather.
Okay.
And also take the C-spine into consideration as well.
Very well. Any more answers?
Yes.
Any more contributions, I mean?
Yeah, so your third point on the case study talks about the patient being drowsy and
yes,
with a very clear evidence that the skull had been probably injured. You would want to do a gloscocoma scale to probably ascertain at the level of consciousness for this patient.
Yes.
To be able to move forward. Also, there are clear signs of injuries to the chest wall. So you want to probably, as you presented a few minutes ago, to do your feeling or your touching and all those things to check for things like crepitation and then subcutaneous emphysema and other stuff on the chest wall.
Well, I mean, so the if you look at the scenario, it says there's decreased breath sounds over the right chest. What are we suspecting here?
Pneumothorax.
A possible pneumothorax, yes.
Yes.
And would you want to intervene for this patient?
Yes, you would want to intervene, and just as you said, you would want to probably do a needle decompression before it turns into a more severe one.
Well, so if I may clarify this, if it's a pneumothorax, yes, you want to get your things ready for the physician to put in your chest tube.
Yes.
However, remember that a simple pneumothorax can lead to a tension pneumothorax. At that point in time, you want to do another decompression followed by a prompt insertion of a chest tube. Okay. So we've mentioned, so what are some of the patient's possible injuries? We've mentioned pneumothorax. Do we have others? Yes, sir. Please go on. Beryl.
Hello, my name is Beryl from Kenya.
Hi, Beryl.
I would also think of the patient is complaining about abdominal pain.
Okay.
I would think of doing a fast.
Excellent. You want to find out what's happening in the abdomen.
Yes.
Right. So I have some answers here. Somebody's talking about shock patient with chest trauma, and most probably pneumothorax, hemothorax. You want to do a two-bore cannula, ideally an 18 gauge, 16 gauge, if you have access to those ones. What are some of the interventions that need to be done for this patient now? CITO, please.